Okay, I don't know if I was speaking too quietly in that last recording. When I listened to it, it sounded kind of low, so sorry. I'm going to move this microphone a little bit and hopefully it can come in a little clearer. Now, the next section is Chapter 7 and Chapter 8. Chapter 7 covers the pediatric, pharmaceutical considerations in the pediatric, and 8 in the geriatrics. There's a lot of correlation between the two, so I decided to just do a summary of these two chapters together. Well, the pediatric pharmacology, limited research because of the risk, needing informed consent, and then finally there was a Research Equity Act of 2002, which was very important and helpful in being able to get a law where we needed to do some monitoring of pharmaceutical response in the pediatric population before making assumptions, since their whole metabolism and body is totally different than an adult. Ran through that, I can't remember what year they actually started using women. For many years, women were not used because of the fear with the childbearing age, childbearing effects, and still there's limited, most are done on men, but women, a lot of things were not researched for that same reason. Okay, here we go, that famous pharmacokinetics, which is that action, or the ADME. We'll start with the absorption, multiple influencing factors, the child's age, which you think of the child's age, that's their body size, the body surface area, their how much albumin, how much skin tissue, how much fat they have, how slow or fast the gut is working, how much acid is in their intestinal tract into their stomach, whether they have any underlying disease, what route of administration you are going to use. Often you might use a sub-Q versus an intramuscular child, which is going to slow down resorption. Might be limited on getting some things given orally. Their skin will absorb much faster, so you're going to adjust the dose of giving something tough. Didn't hear. Blood-brain barrier. The very young infant, the blood-brain barrier is immature, and more medications may pass through that blood-brain barrier into the nervous system and increase the chance of toxicity. It gets better as the child gets older. Again, we're looking mostly at the infant, the neonate, the very young child, probably under the age of 2, and the next group would be under the age of 6 when you're looking at problems with age. Okay, metabolism. Maturational level of the child, first pass effect, higher metabolic rate. The very young child before the age of 2, their liver is not as functional as it will be later, so the liver enzyme levels are low and medications are metabolized slower. So you want to look for adverse effects of breaking down that medication. Their metabolic rate is much higher, so things are metabolized much faster, and they may need higher frequency of medications compared to an adult, especially when it comes to something like a pain medication. Might need to increase frequency if their metabolic rate is high and they are breaking through it. Excretion. Kidneys. Infants have decreased renal blood flow, GFR, renal tubular function, so they're not going to clear things as quickly. Pharmacodynamics, which is the action and effect of a drug in the body, onset, peak, duration, the half-life, everything we talked about before. Previously, it may be different in children than it is in adults. Pediatric variables such as organ function, development factors, administration, effect, drug, pharmacodynamics. So if you're thinking about actions, let me go to the next slide. Nursing implications, medication dosing and monitoring, monitor for therapeutic effects and adverse reactions, calculations. So when you're looking for therapeutic levels, you want to make sure, because a lot of times what's listed is the therapeutic levels for adults, and you need to find actual therapeutic levels in the pediatric population for the age group you're looking for safety. A lot of times that will be established through studies or things, or asking the pharmacist. When I worked in hospitals, a pharmacist was my best friend, and then working as a provider, the local pharmacy was my best friend. Always calling, clarifying, asking. They are a wealth of information. Ask them questions. Okay, so your calculations. Safety, 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 safety. Just most pediatric doses will be weight related, so you're going to calculate per kilogram per dose or per day. So getting used to how to break it down per kilogram is 2.2 pounds per kilogram. So you take their weight in pounds and ounces and break it down into kilograms and calculate their dose. Do that calculation more than once. As a provider doing family practice, any prescription I gave for a child when I was doing weight-based, I did my calculation 3 times. For years, 9 years, I always did my calculation on pediatric population 3 times to make sure that all 3 times I got the same answer, then I knew it was safe. Okay, medication administration. Of course, identifying. You're dealing with a child, so you're going to use multiple identifiers on everyone, especially with the child, the parent, the picture ID, other things, developmental cognitive differentiating, developmental from chronological age. Just because a child is 15 years old, are they developmentally, intellectually 15 years old? Had something in the health department with students last year, and the student was going to do a physical on this teenager that had Down syndrome, and when looking over the records, she realized that the visual screen said it was 2200, meaning like legally blind, and this child did not even wear glasses, and there was no evidence of any visual impairment. Discovered that the aide that did the visual screening used the regular letter chart, but cognitively, developmentally, this teenager was chronologically 15 years old, intellectually like 5 years old. Went back and did the visual screening with the shapes, and the vision was perfectly normal. So that's one of the things, is making sure you're going with their developmental and chronological when you're doing administration and teaching. Safety with minimal restraint. Again, at the end of Chapter 7, there's that nursing process, patient-centered collaborative care. Look over that, and then we get along. Go back. Yeah. The absorption, their gut may slow down. It may be less acidic. Distribution, they may have less weight on them, less albumin protein stores. Their metabolism is often much slower. Their blood flow is decreased, so their blood flow to their skin, and their skin, their skin is not as, definitely if you compare it to an infant, so the absorption through the skin is slower. The liver function may be decreased. The excretion often will have problems with slower metabolism, resulting in slower excretion from the body, decreased kidney function, creatinine clearance, bowel elimination. And all these things contribute to possible difficulties with adverse effects or toxicity with medications. This is the loss of the protein binding sites, increased adverse to clean hepatic, first pass metabolism, prolonged half-life with the drug because decreased liver and kidney, which I touched on. A lot of this is just, you can really just reason your way through it, read through, be familiar, look through your chapter. It's well written. Age-related changes in the central nervous system potentiate the effects of this, of the drug effects. Changes the number of drug receptors. If there's less sites, they cannot have the key fit in as many places and may not be as responsive to certain things. Compensatory response to physiological changes is decreased. They may be dizzy and not have the quick responses to prevent them from falling, leading to injury. The text does a really good job, starting on page 91, on selected drug groups like hypnotics, because yes, sleep is often an issue, difficulty falling asleep or staying asleep, difficulty falling back to sleep if they wake up, so they may take over-the-counter sedative or may have prescription sedative or hypnotics. It's the second most common group of drugs taken over-the-counter, and so if they're also taking something over-the-counter like diphenhydramine, Benadryl, diphenhydramine is found in all over, or almost all over-the-counter sleep aids like Tylenol PM, and they may be prescribed something also, and they're not able to metabolize it as well. If they're taking a benzodiazepine, such as like Xanax, they need to have a much lower dose. To decrease their potential side effects. On page 92, diuretics and antihypertensives, again, if they're may need a lesser dose. Hydrochlorothiazide, HCTC, is a common medicine. It's actually one of the first things you're supposed to prescribe for hypertension. It's on the guidelines, but it can cause electrolyte imbalances, especially low potassium, which can lead to further issues for an elderly person. And more elderly people will have hypertension due to the elasticity in your vessels is getting less and less, and the blood pressure will go up. And certain diuretics will have blocked some of the receptor sites for their antihypertensives. Down cardiac glycosides, which is digoxin. Lanoxin is a common drug that you will see in the elderly, helping to regulate their heart rhythm. It has a very narrow therapeutic index, a very long half-life of almost 3 days. Most of it is eliminated in the kidneys, so many factors can cause an issue with it becoming toxic. Anticoagulants, often because they've had a DVT, a deep vein thrombosis at some point, or they've had a valve replacement, or they've had a stent put in, so they're on anticoagulants, and you need to be monitoring their proton, their INR, to make sure that the range stays therapeutic, and that they're not taking many of those herbs over the counter for multiple supposed reasons that's going to decrease platelet aggravation and increase their bleeding risk. Most antibiotics are safe. When you get into certain antibiotics like the gentamicins, you have to be a little more careful because of renal function. Let's see. Many elderly are on some type of antidepressant, and you want to be careful with serotonin syndrome or things where the affects interaction of medications or toxic levels. People don't think about opioid abuse in the elderly, but it does exist. They can be dependent on it just like anyone else. The body builds a tolerance. They may end up with an addiction. They will have increased problem with constipation, decreased elimination, increased risk of falls. So there's an awful lot of teaching that goes on when it comes to medications. It's really good little prevent medication error safety box on page 93 that you may want to look at some of these medications that look and sound awfully close. Okay, health teaching, special considerations, reading eyeglass, functional hearing aids, speak in tones so the patient can hear. Do not assume that they have a hearing problem. Don't talk to them as if they're children. I've noticed that. Some people speak, I don't know what they're thinking. They talk loud and they speak as if they're a baby. They're not children, they're not a baby, they have lived a life. You just need to speak clearly, speak to them, and make sure they understand. And expect that the patient can learn. I like that. Review all medications at each visit, whether you're doing home health, they're coming in the hospital. If it's a planned visit to the doctor or the hospital, take all their medications over the counter. Everything they take, put it in a bag and take it all with them. And very, very helpful to teach people to keep a little handwritten list that is updated. Encourage a simple dosing schedule. You may want to encourage medications that you can take once or twice a day instead of 4 times a day. Using pill containers to help with the order of the medications. Also important, if they take bottles into the office with them, you can see if they're really taking everything, if they have 2 or 3 of the same thing, if they're going to more than one provider. And then you report if things are not getting better when they're taking their medications. I think that is the end of this one. And again, there's that nursing process, patient-centered collaborative care at the end of the chapter on page 95.